Thank you very much for the introduction. So we're going to be discussing the utility of genetic analysis in long QT management. First, I want to highlight the clinical dilemma here and the overlap of phenotype. So if you look at, this is a study by Taggart and Ackerman in 2007. If you look at Gaussian distributions of QTC intervals in the first peak, which is in males, the second peak, which is in females, and compare that to the Mayo Clinic long QT syndrome cohort, which is, I believe, hundreds of patients with long QT syndrome, you see that in terms of standard deviation curves, there is significant overlap there in the middle, where you can be a long QT syndrome patient, have a QTC of 430 at relatively high probability, or obviously be a normal patient that falls right into the median of the standard deviation. So the issue becomes, of course, that the ECG as a screening tool really isn't 100% effective. There are patients that fall in the gray zone, if you will, where we call them borderline QTC prolongation or upper limit of normal, the ways we use clinically to dance around that issue. So what is the yield of genotype testing? We touched upon this yesterday briefly, but if you examine long QT syndrome as a genetic test, you see that the yield of genetic testing is about 75%, 80%, meaning that if you have a patient that is known phenotypically to have long QT syndrome, you do a genetic test, there's a pretty high probability that that genetic test will be positive. Contrary, if you have somebody with long QT syndrome, phenotypically, there's a 20% chance that their genotype is going to be negative. In other words, there's 20% that are elusive genetically. If you compare that to the percent of controls with the rare VUS, which is a variant of unknown significance, what that means is this variant is neither shown to be associated with long QT syndrome, but is also not necessarily seen in a normal population. So this occurs oftentimes with new mutations. That occurs at a 4% hit rate in a general population. So 4% of patients will have a gene mutation that we really can't identify further. So that tells you that the signal-to-noise ratio in long QT syndrome testing is about 19:1, which comparatively to other channelopathy syndromes is excellent. If you look at CPVT, the hit rate is a little bit less, but the VUS rate's a little bit lower, so your signal-to-noise ratio is actually favorable. Now, if you look at Brugada syndrome, for instance, the hit rate is quite low, giving you a 10:1 signal-to-noise. So in comparing all of these, long QT syndrome is probably top 1 or 2 in terms of yield in genotype. So what are the cornerstones of therapy? So if we're talking about management, how does management affect everybody? And then we'll discuss further how subtypes are important. So drug avoidance, all the medications that are QTC prolonging are important to avoid. This goes across the board for any patient that you think has long QT syndrome, regardless of what you think the genotype is, regardless of what their symptoms are, and regardless of the degree of QTC prolongation. You tell them all, avoid medications that prolong the QT. This is the website that I refer my patients to. You can type in the drug name, and it'll pull up the drug and tell you whether it's conditional or for sure risk for causing torsades or QTC prolongation. Trigger modification is also a cornerstone of therapy for patients, though. When you tell a patient what triggers to avoid, genotype, as we discussed in the last lecture, is very important. So if you're dealing with a long QT1 patient, exercise is a known trigger, specifically swimming. We are currently in the process of publishing data on sports participation in long QT syndrome patients. Though, as liberal as that might seem, I still think we draw the line in long QT1 patients with swimming. We could say, you could play football, you could play baseball, but you can't swim, at least not competitively, because of what we know about long QT syndrome and swimming. Long QT2 patients' trigger avoidance is emotional stress, arousal. Long QT3s, we'll discuss, it becomes a lot more hairy in terms of trigger avoidance. So long QT, you can't swim. Long QT2, This sounds perhaps comical, but in our pediatric patients that are at school, we know that alarm bells between classes mark the end of class, and patients have had triggers by alarm bells. So we talk to the school and we say, is there any other way that you can tell a kid that class is over other than ringing a bell? So instead they have the teacher announce it instead of ringing a bell. We can't study that, of course, to say that it's reducing risk, but it seems plausible. Postpartum patients, postpartum women are also high risk, particularly 2 to 3 months after. There are all sorts of triggers that occur postpartum, as many of the mothers in this room know. But what do you tell them? Not to get pregnant, obviously you can't do that, so you have to be careful with it. This is an interesting consensus statement. Because sleep deprivation and disruption are particularly bad for women with long QT2 in the postpartum period, it is advisable that fathers find the proper way to feed their infants at nighttime without waking their mother. So all the fathers in the room, think about this the next time your newborn is crying. Trigger avoidance, we know that sleep is a trigger for long QT3. You can't tell your families to not sleep. This is the most difficult clinical scenario. When we have a patient with long QT type 3 and the families ask, well, how can I protect the patient? In honesty, you have to say, well, one of the triggers is sleep, and you really make psychogenic basket cases of these families. I'm not judging. I feel like I would be the same way as a parent in this scenario. It's very difficult to instill any sort of reassurance in these patients in long QT3. To Dr. Zimmer's question earlier today, what are the cornerstones of therapy in terms of medicine? Beta-blockade is really considered the cornerstone in all long QT subtypes, and we'll discuss that in more detail. Efficacy of beta-blockade, again, Silvia Priori published this in JAMA about 10 years ago, looking at beta-blockade and the different long QT subtypes. Long QT1 in terms of event-free survival had the best outcome. Long QT2 followed. Long QT3 was actually relatively poor response to beta-blocker therapy. I bring up this in long QT1 and 2. This is a very important slide, and I feel like most electrophysiologists actually don't practice in this manner. But when we're prescribing beta-blocker therapy for long QT syndrome patients and CPVT patients for that matter, propranolol and nadolol are really the cornerstone of therapy. We tend to avoid drugs like metoprolol, atenolol, the selective beta-blockers, for this reason. A study about a year ago showed that that symptomatic number of symptomatic patients on non-selective beta-blockers was actually much lower than it was in metoprolol or atenolol. When we see referral patients at the Cleveland Clinic that come in on metoprolol or atenolol, actually will change them to propranolol or nadolol. So long QT3, if the trigger is sleep, as Dr. Zimmer astutely questioned, why do we give them beta blockers? And it's not that we give them beta blockers as a general prescription, propranolol, nadolol, atenolol, metoprolol. We say specifically that propranolol is the drug of choice. And the reason why is we know that propranolol does affect the sodium channel current more so than nadolol does, more so than metoprolol does, though the efficacy of this is still debated. So even though we use propranolol, there's no studies that show clearly that there is reduced risk or reduced symptoms with that therapy. Mexiletine, however, is a little bit different. There actually is evidence that at least shows that it can shorten the QTC. So mexiletine is a class 1B antiarrhythmic medication, affects the sodium channel as well. It can shorten the QTC, as we discussed, in a small subset of patients. And certainly if somebody has recurrent symptoms or documented torsades, oftentimes these patients will be on mexiletine, but we'll give them a trial with an IV medication like lidocaine to see if a sodium channel blocker will affect their QTC, and oftentimes it does. So who is a candidate for more aggressive therapy? So the prescription for everybody is trigger avoidance. You're on a beta blocker of some sort, and we expect them to avoid medications that prolong the QT. But who's really a candidate for higher, more aggressive therapy. And that really depends on phenotype and genotype, of course. We saw the pyramid that was published by Priori in the last lecture. This was embellished a little bit by Dr. Ackerman, where he really looked at risk stratification in terms of whether it was genotype guided, phenotype guided, or a combination of both. And if you look at the purple, you see that very, very high risk patients are the Timothy syndrome, the Jervell-Lang-Nielsen syndrome patients, which have long QT syndrome and congenital deafness, the autosomal recessive long QT, which there is some overlap with Jervell-Lang-Nielsen syndrome, and then obviously anybody that has had several events before the age of 10 years old. So if you've had multiple syncopal events, cardiac arrest, what have you. And then you look into genotype in the high-risk group, long QT1, long QT2 patients that have QTCs more than 500, or if you're male and have a QTC that's more than QTC that is more than 500 and you're long QT3. And then again, genotype plays a role in terms of determining intermediate risk and low risk. And there's also phenotype, number of syncopal events, so on and so forth. But clearly here, genotype is part of the risk stratification process. So if you are extremely high risk or very high risk categories, left cardiac sympathetic denervation is one strategy, and implantable defibrillator is another. Another relatively recent article assessed the location of the gene mutation in terms of risk stratification. We touched upon this earlier as well, though I want to highlight this is the long QT1 gene. They looked at the patients with mutations here in the cytoplasmic loop and found that those patients with that locale of mutation were the highest risk of developing symptoms. What were their responses to beta blocker therapy? Fortunately, those patients with C-loop mutations, though they had the highest risk of events, had the best response to beta blocker therapy, whereas patients with non-C-loop mutations had sort of an equivocal reaction. This perhaps is, at least in part, explained by the fact that if you're low risk already, it's probably hard to establish a efficacy in beta blocker, whereas if you're high risk, the difference becomes much more evident. In my opinion, the main reason to follow the genotypic trail and the main reason why genotyping is so important in management is you want to know who else in the family can be affected. The patient that you're seeing that day that is compliant with your medication prescription, that is a long QT1 or long QT2, almost regardless of their risk stratification, is going to be relatively low risk if they're compliant. The issue is the brother that's undiagnosed, the uncle that's undiagnosed, the cousins in the family. So certainly this is not the most complicated genealogy I've seen, but you see that an affected, this is a long QT, this is the patient that I saw. The father was affected. His brother died suddenly at 18 after his alarm clock rang to wake him up for class. But his brother has 3 siblings that are all undiagnosed, that haven't been genotyped, and all have children. And those are the people that we really need to find. So the consensus statement on genotype testing says that comprehensive long QT 1 through 3 testing is recommended in any patient that a cardiologist has a strong clinical suspicion for long QT syndrome based on family history, based on clinical history, based on ECG. Comprehensive testing is recommended for an asymptomatic patient with QT prolongation in the absence of other clinical conditions that can prolong the QTC, like drugs, like electrolyte imbalances. So there's clearly a role for genotype in our patients. So to answer the question, is genetic analysis of long QT syndrome essential in management? I think that is a strong yes in long QT syndrome, but the caveat here is hopefully somebody pays for it. In the United States, at least, private insurance companies tend to balk on long QT syndrome testing if they think that your clinical suspicion is low. You can always make a claim, fight them. We spend a lot of time, unfortunately, doing this. But ultimately, this is a barrier. Probably 10% or so of our patients cannot get gene testing for those reasons. We could refer them to research labs, which is something we've discussed, but commercial testing is not available for everybody. And I'll take any questions if you guys have them. These are my 2 children.
For any patient who comes to the ER, asymptomatic, incidental finding of a QT 500, 520 milliseconds, I refer to the cardiologist and leave the rest of the decision.
The QT is how long again?
Say 500, 520.
A 500 or 520 is, that's probably crossing the line in the sand. It's pretty unlikely that somebody with a 500 or 520 is going to be normal. A patient like that who had, the problem with the syncopal events in a patient with a QTC that long is their recurrence risk in 24 hours is actually very high. So somebody like that should be seen right away. The likelihood that that patient's going to have an event in their entire life is highest in the next day. So you don't want that patient going home untreated, or at least going home without some sense of what they can and can't be doing, sports, things like that. So that patient should be seen. That being said, the more common scenario is you have a patient with vasovagal syncope that gets an ECG and the QTC is 460 or 470 or even 480, where it's upper limit of normal or maybe low for a long QT syndrome patient. Those patients who have a pretty clear vasovagal syncope story, we typically recommend that the ECG is repeated in a week or two. We know that vasovagal syncope patients immediately after their event, 24 hours or so after their event, will have mild QTC prolongation that just resolves in a week or two. So we wait. If the QTC is still long in a week or two, then we're a little bit more suspicious. But that was actually published in Pediatrics, that phenomenon, about 3 years ago or so. So it's a pretty well recognized thing.
What about ethnicity or hereditary? Is there a variation in a different part of the world regarding the QT?
That's a good question. I spent a lot of time digging this up, and all the literature reports that there is no race discrimination or gender discrimination for that matter in long QT syndrome. It affects all populations, all races equally. I don't know what the experience, I would be very interested actually to hear what the experience is here in the Gulf. If you guys have any data on that, please share it with me.
We don't have data, but definitely it is much less than what we see in Bulgaria, for example.
Yeah.
It's our colleagues in pediatric cardiology. I talk to them. I think they do see few families, but in adult we do see, but it's not
It's common.
Not as common.
It's very interesting. The exact opposite is true in the United States, of course. Brugada is not a very common channelopathy there, whereas long QT syndrome is quite common there.
So if there is no further question,
Thank
you
you.
very much for
Thanks.
the excellent